So apologies, I don't know why the music didn't play, but take it away.
Okay, thank you. I'll see if I can share my screen here and we'll get started. All right, so to introduce our talk, first thank you for having us and giving us the opportunity to present what for us is a very interesting topic. We hope it'll be of interest to you. For early career psychologists, we hope to share with you some practical tools that we found useful and have drawn on the work of many other psychologists. And for those of you that may be more statistically inclined than I, we'd also welcome your feedback as we go through these practical tools for attempting to improve diagnostic accuracy. If there are things about our approach that you find that there may be some flaw in our assumptions or our reasoning, we welcome any input since some of this is a work in progress. So what we'll be going through are a series of examples to try to demonstrate how we can use Bayesian analyses to try to obtain the most information possible out of test scores that we derive from an individual examinee. So unlike a statistical analysis that might compare two groups of people, and we may use traditional or frequentist statistics, our interest in Bayesian statistics is very practical, and what we're attempting to do is to determine what is the probability of a condition of interest, the diagnosis, based upon a single test score. And more importantly, if we're able to move beyond that, based on an aggregate or a joint conditional probability of multiple test scores. So that's kind of an overview. And the examples that we'll be using are looking at test scores from a test of for malingering, the TOM. We'll also look at some tests trying to move from a pre-test probability to a post-test probability for ADHD, autism, some aspects of Parkinson's disease, and then we'll share with you where we're at in our attempt to develop a machine learning algorithm to assist the diagnostician in the differential diagnosis of different neurodevelopmental conditions. So in this process, here are some of the resources that we've identified that we want to acknowledge. First is a statistical program that's made available by the JASP team and Dr. Eric Jan Wagenmakers. Secondly, software that's made available by Professor John Crawford. Both of those are freely available and have been generously posted so that if you're interested, you can also check those out. And toward the end, I'll be hopefully having time to demonstrate a machine learning software program called Bayesiolab, developed by a French company. So the point of departure for this is why all the math? Why do we need all of this? And the crux of it is that there's been decades of research in psychology as well as behavioral economics about the pitfalls of human judgment. And there's too many references for me to provide for this, so I'm just going to hit upon a few, going back as far as Francis Bacon and his work, The New Organ, or essentially an introduction to the scientific method. And I'll just point out a few quotes from Francis Bacon. The human understanding, when it has once adopted an opinion, draws all things else to support and agree with it. So here we have an early anticipation of what we would now call confirmatory bias. And he goes on to say, it's the peculiar and perpetual error of human intellect to be more moved and excited by affirmatives than by negatives. So I think this point kind of captures both a representativeness heuristic or also a saliency bias. So these are heuristic biases or shortcuts in mental reasoning, which although they can be useful, may also lead us to making errors in logic. So how this all applies to diagnostic reasoning, I've tried to sort of encapsulate in a little diagram in the bottom left, where we have a simple 2x2 contingency matrix, and COI refers to the condition of interest, the diagnosis, whether it's actually present, or the condition, whether it's present or absent. And on the left column, a positive test result or a negative test result. And the simple point is that many clinicians are tend to be drawn toward the positive test result as being indicative of the condition being present. And that may be the case many times, but we need to attend more to the other cells in that matrix instead of just focusing on the positive test result, reflexively leading us to conclude that the condition is present without understanding or knowing the sensitivity or specificity of the test or the base rate of the condition of interest. So in terms of other work that informs what we're attempting to do, I'm sure many of you are familiar with the work of Daniel Kahneman and Tversky in economics and in psychology, and essentially their focus is on decision-making under uncertainty, which is quite relevant to the diagnostic process. Here are some examples of heuristic biases, and I'll try to tie these in with examples that pertain to diagnosis, since as a practicing and primarily a clinician, my interest is if I have a child or an adult, I'm doing a diagnostic evaluation, what are these biases that I need to be aware of and sensitive to? So the first one we've already mentioned from Francis Bacon, confirmation bias, and that refers to the tendency to kind of pay attention to information which confirms our, say, initial impression of a diagnosis and perhaps overlook other information that may disagree. Representativeness heuristic refers to making judgments about the probability of an event based on whether it's similar to, say, a prototype. So an example of this may be if I work with children and I'm doing a diagnostic evaluation for ADHD, and I have in my mind sort of a representative prototype of a child with ADHD, and it's this child who's restless and fidgety and all around the exam room and taking the alcohol foam and making a Santa Claus face out of it. That's my image of, say, the typical ADHD child. And then I have another child the next day who isn't all around the room, but maybe that boy or girl is very inattentive. So the danger would be in the diagnostic reasoning if I simply relied on this idea of the prototypical hyperactive ADHD child. The availability heuristic refers to recent information, perhaps having more of a influence on a diagnostic decision than it should. That could be based on something I've been reading about just prior to seeing a case, for example. A saliency bias is that people are drawn to what's the most emotionally striking information. So an example of that would be in the world of news. What is newsworthy? Well, if it bleeds, it leads. And similarly with diagnostic testing, as I mentioned before, we tend to be perhaps drawn more toward positive findings being associated with the likelihood of a condition and overlook other information. And then finally, illusory correlation as it pertains to diagnostic reasoning may be a tendency to overestimate the correlation between an individual test score and the presence of a condition. So hopefully with our published tests, there is some correlation, but if you don't really look into the psychometric properties of the test, there may be a tendency toward overestimating that correlation. So that's why I love test manuals and encourage you all to, when you adopt a new test, be sure to look at the manuals as well as the appendices, because there's a lot of information available there, and we'll talk a little bit about that. Sir William Osler, Medicine is the Science of Uncertainty and the Art of Probability. So essentially our talk has quite a bit to do with the use of probability for diagnostic reasoning. Claude Shannon developed information theory and really defined information entropy as a measure of information content of a message. But interestingly, it's defined as the extent to which it reduces uncertainty. Does the message reduce our uncertainty? And so similarly in diagnostic reasoning, we think that the diagnostic evaluation shouldn't be a process of increasing our confidence, say in our initial impression. Diagnostic evaluation should essentially be a process of decreasing uncertainty, where we start with a lot of uncertainty, obtain information, and progressively become less uncertain as we go until we narrow it down to what the most likely diagnosis is. So now I'm going to pass it over to Karen and ask her to talk with us a little bit about Bayes' theorem.
Okay, thank you, Tim. let me just try and share my screen here. Give me one moment. Can you guys see that okay?
It's on the presenter view.
Okay, give me one sec. So I don't want to waste too much time. I'll just share what I have here, if that's all right. And just like Tim said, you know, we want to get as much information as possible from each test score. And just returning to that 2x2 matrix that he introduced earlier, you know, as psychologists, we're familiar with this. You know, we work with this all the time. You know, we have test sensitivity, we have test specificity, but we also have positive predictive values and negative predictive values that we can get about a condition. And usually what many psychologists do is they spend a lot of time focusing on the sensitivity and specificity of a test, which is very good. Those aspects are really important. But what I wanted to kind of emphasize today is that, you know, we really want to spend a little bit more time from a Bayesian perspective thinking about the positive predictive value, which, you know, when we're looking at the rows across, we're looking at the correct categorization of people having or not having the condition of interest, whereas the columns are really more concerned about the test itself. So I think it's important to kind of keep that in mind. And the PPV is very much similar to what we're trying to assess when we are doing Bayesian analysis. So this is Bayes' theorem, and some of you may or may not be familiar with this. It might be a little bit scary looking, but I was really happy to hear that the probability was actually mentioned in the previous lecture, the previous talk by Dr. Tottenham, which was a really great talk on emotion regulation. She alluded to the balloon analog risk test, which is a test of decision making, but it's also a test of implicit probabilistic thinking. And so basically, this is a quantification, if you will, of what's happening in our minds and what's happening in the environment when we're trying to understand if there's a condition, if there's evidence of a condition in our clinic. So basically, this theorem is telling us, you know, we're trying to find the probability of having the condition, which I call H, given the data. And this is what we're trying to do as scientists. What are we basing it on? Well, we're basing it on 3 pieces of information. We're basing it on the probability of the condition, which is called the prior. And this represents our initial belief about how common we might think this condition is. We also have the likelihood, which is the probability of the data given the condition. That should say D and that should say H. That's a typo there. And then this is the marginal probability. This is the probability of getting the data. So if we were to break this down, we would say that this is a probability, again, of having the condition, of having the data, of getting the data if you have the condition. And these are all independent of each other. And this special notation here means not. So this is the probability of having the condition times the probability of the data given the condition, which is basically the numerator. And you're just adding to that the probability of getting the data if they didn't have the condition, times the probability of not having the condition at all. So if we wanted to break this down and use terms that we're familiar with in psychology, what we're doing is we're basically looking at the prevalence or the base rate and the data itself. So the prior probability in this case would really be the prevalence or like I said, the base rate of the condition. That could be autism, it could be Alzheimer's, what have you. The likelihood is the data that you're presenting to the table. The denominator right here is going to be derived from the specificity and the prevalence data that we have about the condition. And I think, Tim, this is where you take over. So I'm going to stop sharing my screen.
Okay, thank you. Let me bring my screen back up. Okay, so I'll be continuing now with some examples of applying Bayes' theorem to some common tests and what type of information we can derive from that. So the first example is the test of memory malingering. Many of you will be familiar with this, and I'll be talking about an example of a score on trial 2. And this approach is not new to us, certainly, but I just want to use this as a straightforward example to orient you to the type of information we can obtain by using JASP to help us look at this example. So we have a trial 2 and an examinee, an individual examinee's test score. And for those of you that aren't familiar with the test, there's 50 items, and there's a probability of each item being either correct or incorrect of 50%. So here's some information about the JASP program, and our example is trial 2 raw score of 17. And the question is this score significantly lower than the random range? Now, this is a very stringent way of interpreting this test. We know that there are norms for different groups of people, normal, healthy individuals versus other groups, but this is really just an example of applying a Bayesian binomial test to answer the question, is this score of 17 significantly less than the random range? So if we are using the JASP program, what we have in the left side of the screen is a test value of 0.5, which represents the probability of a correct answer for each of the independent test items. And we're going to use a non-informative prior, which in this case essentially means we're not really paying attention to how easy or hard the test is, or assuming no other knowledge about the test, only that it's a 50-50 chance of each test correct. And when we put the data in for a score of 17 out of 50 correct, what we derive using the Bayesian binomial test is a score called the Bayes factor. And on this slide, we have the results of this, and we can see the Bayes factor in the upper left, which I've put in the red box, is 4.43. And this graph, which is also derived from the JASP team, helps us to interpret what's the meaning of a Bayes factor in this range, and a score of 4.43 provides moderate evidence in favor of the alternative hypothesis. So in this example, the null hypothesis is the score of 17 is essentially in the random range, and our alternative hypothesis is that it's substantially lower than the random range. So in this case, we have moderate degree of evidence that this score, as you would probably intuitively understand, is moderately below the random range. These pie charts here are a quick and useful way that this information is represented in the JASP program, where the alternative hypothesis is represented in the white space, and the red refers to the degree of support for the alternative hypothesis, which in this case is lower than the random range. On the bottom, we have a sequential analysis, which nicely shows us for each item on the test, does that response trend more toward the null hypothesis or the alternative hypothesis? So in this example, I've put in scores for an individual examinee that are trending toward correct responses, and then at some point during the test, trend the other way toward the alternative, toward answering the items incorrectly. However, that conclusion of having a very stringent test of whether the test score is below random, that happens very rarely. Another thing we can do is use some empirical data to inform our analysis of the meaning of a test score. So what we've done here is we've looked in the TOM manual, and in the appendix we find small sample, but helpful, of a dementia, a sample of individuals with dementia on the trial 2 of the TOM. And I've represented that here with this violin plot. So within the dementia group, the raw score, the mean raw score in trial 2 is actually 46. And very few people score, 11% have scores below 40 and 8% below 38, even in a dementia group. So we can then use this information and change our question now from is a certain score below random, and instead ask, is it below the range we would obtain from a group with dementia? What's the strength of evidence that a person, for example, with a score of 38 out of 50 correct, or 0.76, is lower than the dementia group of 46 out of 50 or 0.92? So what we've done is update our JASP data entry to a test value of 0.92, representing the proportion correct for the dementia group. And we ask the same question, is this particular score below the range of the dementia group? And what we find is very strong evidence for the alternative hypothesis that this score is below the range obtained by this small sample of individuals with dementia. So now I'm going to turn it over to Kayla to talk with us about the same approach, different software application, but the same approach to ADHD classification.
All right. I'll actually be using your screen and slides.
So I will put them back up then.
Okay, thank you.
And you can just tell me when to advance.
Okay, I'll do that. I'm going to be talking about how to use this kind of approach to look at ADHD classification accuracy. So this is using the Conners 3 parent rating scales and the Conners CBT-3 scores, which are known as our gold standard measures of ADHD diagnosis. And we're going to include and incorporate ADHD prevalence data for Connecticut along with Bayesian methods to go beyond what's in the test manual to understand the post-test probability in our own clinics. So we're wondering how much certainty do these kind of scores add to our diagnostic process in our own clinics, not just in the manual. So per the manual, this is a lot of information about how the scores were combined, the CPT-3 scores and the Conners parent rating scales. But I think the most important thing to point out here is the sample that was used. So in the manual, the sample prevalence of ADHD was 57 out of 112. So about 50% of the participants in the Conners sample had ADHD. So again, the software that we're using in this example comes from Professor John Crawford. And the ADHD prevalence inputs are epidemiological. So we're looking to find the post-test point probability of a girl in Connecticut having ADHD, given what we're just going to call a positive test finding on the Conners measures. So we're going to use the prevalence data from Connecticut to see how our results differ for a clinic that might be different from the Conners norm clinic. So they saw 50% of their participants had ADHD. For us, we're going to use this Connecticut data. So here in the Connecticut sample, 31 participants, female participants, had ADHD, and there were a few hundred that didn't. So this base rate is a lot lower than what the Conners manual used. So we're going to input all this data now. So we're using a positive test result from the Conners tests, and we're using this objective data from the prevalence study. So these first 4 entries in the column are from the Conners technical manual. And then those last 2 numbers in the column are from the epidemiological information in Connecticut for the base rate of ADHD in girls. So we enter this information and we see it's not circled, but our base rate's about 7%, different from 50%. And the post-test probability of the presence of ADHD given a positive Conners test result is 0.373. So let's look at that kind of more on a graph. So the green shows the pre-test probability distribution based on the base rate. So that's just the likelihood of a girl in Connecticut having ADHD walking into the clinic. Then the red curve shows the updated post-test probability distribution based on the positive Conners test score. So you see the shift to the right, so an increase in probability. We get up to about 37%. but that's not as high as you might imagine it would be. And as we've kind of been talking about, clinicians we can sometimes reflexively assume that a positive test result indicates the presence of a condition. This person has high scores on the Conners Parent Rating Scale, they bombed the CPT, and they probably have ADHD. But this Bayesian approach is showing us that based on the base rate of ADHD in girls in Connecticut, because it's so low, the positive test result doesn't shift the probability as much as we might expect. So in this case, the manual makes the test look like a positive score, which shifts the probability much further. But that's because the base rate in their sample was so much higher than what we see locally in our own clinics.
Okay, thank you. And I would add to that, so we have two examples there. The manual refers to a clinic with a very high base rate of ADHD, and then the community sample is on the other extreme. And in the middle is the value of obtaining your own local base rate data or coming up with an informed estimate, which could also be used for this. So I'll be now going very quickly through a few other examples. These refer to the tests that try to help us understand the probability of the presence of autism. It's the same method, so I'll go through quickly. It's just substituting the information and seeing how, to what extent do the data shift the post-test probability based on the test as well as the prevalence of the condition. So here's a confusion matrix for the Childhood Autism Rating Scale, also derived from the manual. And in this sample, the prevalence of autism is 0.58, and their classification accuracy index, or one of them, is 0.93 based on this. But we're going to integrate some epidemiological data. This is national data set for our information about prevalence. Do the same thing, put the information to try to derive the interval estimates for post-test probabilities using Crawford's application. And we see, in this case, for this particular test, using the community-based prevalence data, the post-test probability is 0.162. So we've shifted from a very low base rate of the condition of interest to somewhat more given a positive test result. And this is for autism among boys. We can also look at the likelihood of autism with another questionnaire, the Autism Syndrome Screening Questionnaire. Refer to their manual for the same type of information, put that data in, and we see again, in this case, the post-test probability is 0.114, which sort of moves our needle over somewhat, but perhaps not as much as many people might expect given their clinical practice. And then finally, we can use the social responsiveness scale for the same thing. This is from information in the published articles that also refer to a larger interactive autism network study. And we, in this case, use the same type of epidemiological data. And we see the post-test probability for the presence of autism given a positive test result is 0.30. So this moves our post-test probability over a little bit more. So now I'll turn it back over to Karen, and she can pick up here.
Thanks, Tim. You can continue sharing your screen.
Okay.
I don't want to have that kerfuffle again.
All righty.
Thank you. And I'll go through these slides quickly as well. So, we can ask the same question for any type of condition. So if we wanted to take data and predict, the probability of whether or not a patient with Parkinson's disease has dementia, we could use that information here as well. And plug that into this equation. The other thing that I wanted to add, though, was, we don't have to just look at one test. You can complete this same method for any test, like if you gave, a screening test or waist digits or any measure theoretically. And as long as you multiply the posterior probabilities together, you'll get more information to reduce your level of uncertainty. And so the next slide kind of shows, I just kind of guesstimated some numbers, and this is based on MoCA data. If we had somebody with Parkinson's disease come into a clinic and we gave them a MoCA and they scored below 24, they'd have a 68% probability of of having, cognitive impairment or Parkinson's disease dementia. We could apply this using a tree as well, which I think is a little bit easier to understand from a decision-making perspective. So I think what this slide is basically trying to show is that whenever you see a patient, you really, from a Bayesian perspective, you first want to consider the prevalence or the base rate. That's the number one thing. Of course, the second thing that you want to know is, is the person diagnosed with any type of condition? And then you kind of want to take the information from the test statistics to calculate the probability of whether or not they have a condition. So for example, we have 0.96, 0.95, 0.05, and a question mark. Notice that all we really care about is the sensitivity and specificity for people who, in those who have the condition. And we only care about those who don't have the condition if they have a false positive. We don't really care about the true negatives. So I think this is kind of a good visual. In the next slide, I think it's important to consider that this number that we're calculating, it can change. And that's the beauty of Bayesian theory. One, it can change with the prevalence of the disease. We're getting more and more data from more studies that are going on through public health, through psychology. We can improve our prediction model by updating the prior, because that'll increase the probability of detection. The other thing we can do is if we come out with new tests that are more sensitive or specific, that increases our probability, obviously, of detecting a disease. In general, though, specificity is more important than sensitivity. You want to be able to correctly categorize, those who don't have it. The last thing I wanted to mention is that that this graph is kind of showing how things can change. The other thing that I wanted to mention was if you perform a posterior probability calculation, you can use that posterior probability as your prior the next time around, and that's called Bayesian chaining. So the point is that get as much info as possible, keep updating the prior, keep getting more data, and get more accurate results. So the next slide gives you a website where you can kind of play around with that. I'm not going to go over that now, but you can go on that website, move the figures around, and you'll get a sense of how things fall probabilistically on a graph. I could also go over really quickly another real world example of Bayesian analysis. So there was a great study done by Dawson and his colleagues, and they looked at office-based screening for Parkinson's disease dementia. And they developed a kind of scale called the Montreal Parkinson Risk of Dementia Scale. And it applied machine learning to kind of make those posterior predictions. So basically, you have 8 criteria here that you can see in Table 1. And it takes in, sex, falls, MCI status, and so forth. And if you meet a cutoff of 4 or more, then you'll use the data on the right in this testing set to kind of calculate the posterior probability. Again, when you're doing machine learning, in this type of modeling, you're not just taking all the data and just sticking it into the machine. You're splitting the data up and you're validating it. So you set apart, usually by convention, 75% or so of the training data, and you do your modeling on that. And then you apply those parameters onto the testing set to see if it works. So in the next slide, what we find is that we can combine information from that posterior probability with other data. So for example, if we want to take a look at this figure here that looks at hazard ratios, we find that at any time, a patient with a score of 4 or 5 on the MOPARDs, they were about 10 times more likely to develop dementia versus those with a lower score. So if we pull out that value that we calculated earlier in the talk, and we multiply that by 10, that tells us that this particular patient is 7 times more likely to develop dementia or to convert from MCI to dementia in a Parkinson's sample. Does that kind of make sense? I want to make sure that that makes sense to everybody because I kind of flew through it.
Okay.
And this is just a procedure to kind of calculate the posterior. You can.
Okay, thank you. And so we're going to kind of move on now toward what we had mentioned before about not looking at just a single test score, but can we aggregate test scores in terms of multiple probabilities to help us determine the presence or absence of a condition of interest. So our goal in this project, which is a working project still in progress, is to develop a diagnostic decision support tool to help us improve accuracy, diagnosis of autism and other neurodevelopmental conditions, and in the process to identify which elements of the history, symptoms, or test results most efficiently establish the diagnosis with a high level of certainty. So Kayla, do you want to share with us about the Child Mind Institute study?
Sure. So the data we're using for this project comes from the Healthy Brain Network study, which is run by the Child Mind Institute. They're based out of Manhattan. I was a research assistant on this project for a couple of years before graduate school, so it's near and dear to my heart. The project's goal is to create a large, rich database of information to facilitate the discovery of biological markers of children's mental illness and diagnostic accuracy. And the data are released openly to scientists to facilitate this kind of discovery. And the set itself lends itself to big data approaches like machine learning because it has so much information. So it has questionnaires, blood testing data, cognitive measures, and the diagnoses that are assigned to the participants are created through consensus diagnosis through a semi-structured interview, not from the test data. So you're really able to look at the tests separate from the diagnoses to determine their accuracy. So the richness of this data set, I think, reflects the richness of data that clinicians have when we make decisions. We have history and symptoms and dozens of assessment results, and we have to integrate all these to come to a conclusion. And we know that comorbid psychiatric diagnoses are common. In the data set, the Healthy Brain Network data set, individuals can have up to 8 diagnostic classifications. So that means that the number of potentially unique diagnostic combinations is 8 factorial, which is over 40,000. So in some of the previous examples we've been showing, we've been looking at the probability for one specific diagnosis, like ADHD, given one specific test result, like the Conners. But now we're trying to integrate the impact of multiple exam findings on many possible diagnostic categories.
All right, thank you. So just briefly, a few contributors to kind of recognize in terms of the history of psychology. I would put Paul Meehl in this group for his overriding contributions to the importance of actuarial approaches to diagnosis. And in terms of machine learning, just for those of you that may not be familiar, the work of Judea Pearl. The book on the left is more technical. The book on the right is more accessible, certainly for me as I try to understand some of this. There's also an interesting interview link here from 2019. And I'd like to just kind of highlight 2 things here, going back to Francis Bacon in 1620 and then fast forward to 2020. You know, different periods in time, but something very similar comes through. So Francis Bacon talks about this example of the men of experiment being like the ant, as he describes or introduces a scientific method. So the men of experiment are like the ant on the bottom, and they only collect and use observations. And then the reasoners, more the philosophical reasoners, are like the spiders, and they have very abstract theories like cobwebs. And the bee, representing sort of the path of science, goes back and forth between the observation and reasoning. And in this particular example with the Bayesian lab, I was struck by the parallel with the integration of data from the bottom up and knowledge modeling from the top down. And so many other machine learning Products, I'm sure, can do this, but in this example, what we're showing is a sort of data up approach to developing a Bayesian network to integrate this information without any top-down or expert knowledge. So the example here is a simple question: is autism present or absent, yes or no? And in the Healthy Brain Network Child Mind Institute data set, there's 89 or 90% of the children do not have a diagnosis of autism and 10% did. So as was mentioned a little earlier, the approach to this involves a learning data set and then cross-validated with a test data set. And we broke this up into 80 and 20%. And what we see here is a visual representation of each variable represented by a circle or a node in the network. And the one in the center is the diagnostic question: is autism present or absent? And all of the variables around the outside are primarily self-report or parent-completed questionnaires for the most part. Now, there is a problem with our current model because although we've taken effort to remove highly correlated variables, such as a total score on one scale and the subscale scores on that identical scale, there still are some correlations among the variables which can be problematic, as opposed to each input variable being independent. But nonetheless, we wanted to share with you this example, and I may be able to briefly show you how it works with the software itself. So our learning sample had 1,276 cases, and the overall precision was 89%. And this example, was a little bit better with the large number in the learning sample, and then the accuracy dropped down with a smaller case set of 319. And one of the things that influences this is called overfitting, in which the initial, the network learns the patterns of relationships and the conditional probabilities among the variables in the training set and can become quite efficient with that set. But when you have a cross-validation set, the accuracy will often go down if those cases are very different than the ones that it learned on, or if there simply just aren't enough subjects. So we resampled using a k-fold cross-validation, in which the same data set is repeatedly 10 times sampled with a different mix of cases, and these are the findings there. So it's a start in terms of working toward or trying to develop a model that helps us to improve the accuracy of diagnosis, and at some point we may try to integrate some top-down expert knowledge as well. So what this looks like as a visual representation of the data, these are some of the variables. The node in the center is the presence or absence of autism, and each variable is connected to the others by an arc. And here we have sort of the strength of the relationship among the input variables and how they relate to the presence or absence of autism. And this is a three-dimensional representation of what it looks like as a network, which we can sort of physically manipulate and turn for data exploration. So without going into the software, I want to leave some time for questions and also not run over into our next speaker's time. But this is how it does with the developing a preliminary network for the presence or absence of autism. And where we're going with this is the idea of developing a user interface for the practicing clinician, where on this particular monitor, we have a graph which represents the presence or absence of autism, or what's the probability of one versus the other. And in this case, before we input any information or test scores, this is the base rate of autism of 10.43%. And then when we set the evidence for the input variables, it will dynamically adjust the probability of your condition of interest if this model is accurately optimized. And ultimately, the user interface would look like this. This is just posted but not functional at this point. And essentially, the same type of thing occurs as the user puts an individual examinee's test scores into their appropriate value here. The probability of autism in the monitor on the right will increase or decrease. So I think we'll stop there and perhaps invite any questions or comments from others.
Excellent. Thank you. That was a really really fantastic talk. I'm glad to have heard it. I'm just still learning about all this, so this was a great introduction for me. You have a few questions. So in the Tom example, and perhaps I misunderstood, just because there are two choices does not mean they are equally likely to occur. So that should be reflected in the pretest probability. Again, maybe I misunderstood, but I thought it was said the sequential analysis in JASP pertains to number of items, but I believe it only refers to sample size.
Yeah, I'm not sure I caught the last part, but I agree with the person asking the question. The first part of the example was intended to represent no prior knowledge about the level of difficulty of each item. So sort of as an example of simply knowing that we have a test in which each item has a 50% chance of being correct or incorrect if we have no prior information. And then where to go from there would be to then build into that model information about the level of difficulty for each item. So we could have a prior that's informed by how a healthy group of people who are giving good effort perform, and we could have another prior for a group of people who are attempting to feign cognitive impairment. So the example, the first part of the example was intended to be simply assuming that each item has equal difficulty and a 50-50 chance of being correct or incorrect.
Great. Next question. The base rate issue is interesting. Does it make more sense to use a population base rate or the base rate for the individual clinic? If the population base rate of ASD is 2%, but I find that I diagnose 50% of my patients with autism, a biased sample is referred to me, for example, which one would be more appropriate?
I can, do either of you want to add? I have a thought, but let me give you a chance to respond as well.
So I think this is a really interesting question. And I think it ultimately boils down to a judgment call. You know, obviously as psychologists, if we're working in a clinic, we're going to naturally see patients with disease. So that population base rate may not be accurate. I think if I had my independent clinic, you know, I would try to, I might initially start with the population base rate, or I might try to ensure that the diagnosis that I have is substantiated by independent evidence, and then try and infer what that might be for my own clinic. But I'm not sure how you would feel about it, Tim.
No, I agree. I think what I would say to that is that the population-based prevalence is going to sort of yield a lower level of accuracy because we're not taking our neuropsychological tests and walking down the street, knocking on random doors to see, you know, what the likelihood of a diagnosis is. We're all working in locations. So I think that if you have your local base rate data or have a good sense of that enough to have a subjective prior, that's probably going to yield more accurate information. And so our examples were really to sort of compare two extremes, say the technical manuals in which the base rate of the condition of interest is very high, and the community where it may be very low. And ideally, we hope to encourage you to, you know, obtain information about your particular practice and integrate that information.
Okay, and the last question, in the Bayesian network example, which is a very cool visual representation of variable relationships, you noted the high correlations among some variables. Is there a reason not to use partial correlations between all variables to account for the overlap?
I'm not sure. I'd have to, partial correlations, you mean to use the partial correlations prior to inputting the information? I'm not exactly sure. So I'll just mention sort of my thought about that is what we did was, for example, if there were a scale that had a total score only, we would just use the total score. But if there's a test that has a total score and say 4 subscales, we would use the 4 subscales and remove the total score. But each of those, if you look at the factor analysis of the test being developed, they're not completely independent. So there is some overlap there. I hadn't thought of using a partial correlation and then working from there. but I'd welcome whoever the question is asking the question. If you have some thoughts, I'd welcome. It's hard to do this through the virtual world, but if we were in person, I'd ask for more. Would either of you want to add anything to that? No? Okay.
All right, well, thank you very, very much.